Okay, maybe we'll take from the representative of the national chairman of CPAN, Dr. Joseph Madu, Pharmacist Tricia Kukigam. Please, we'll take your remarks now.
Okay. Hello, fellow colleagues. I want to commend them for the beautiful work they're doing. I mean, it's unprecedented. You are doing a good job, and I commend you on behalf of our chairman, Joseph Madu, who is unavoidably absent. He wasn't able to be here, but he told me to stand in for him. I also commend our CPAN pharmacists, clinical pharmacists from the UK and America. You have done a good job, and thank you so much for the information you have given us thus far. I want to encourage us to be part of the good thing that is going on. Just as Ilorin also gives us information through Zoom meetings, I want to encourage us, our pharmacists from the UK, from America and other parts of the world, to please use the Zoom meeting as a medium to tell us what is going on in your own country, so that we can also learn from you. This has been a wonderful session. I want to encourage us. Our chairman, Joseph Madu, he has done a wonderful job. He has always encouraged us, especially in the language we use, how to speak as pharmacists, how to place us as pharmacists above everyone else in terms of collaboration. When he's mentioning the clinical pharmacists, he always mentions the clinical pharmacists first, the nurses and the physicians last. He's just actually trying to make us be on top and to build our confidence in us as clinical pharmacists. So I have a lot of questions for the panelists, but I will stop my speech here and allow others to continue. Thank you so much on behalf of CPAN Nigeria. Thank you so much.
Thank you very much. Pharmacist Lawrence, are you back online? Okay, I can see Dr. Kingsley Amebo. Yes, please, we will take your remarks now. Thank you once again, Dr. Kukigan.
Thank you.
Yeah, Dr. Kingsley Amebo, please. You have the
Yes. Thank you so much, my friend, my very good friend, my chairman, to those of you. I must confess that I'm excited at what I'm seeing here this afternoon.
Thank you very much, Pharmacist Lawrence. We are very grateful for that. And in a nutshell,
Dr. Lee, I'm done. Thank you.
Okay, thank you very much. Okay, Edgar. Okay, so thank you very much, Pharmacist Lawrence. We are very grateful for that. And in fact, on our chat, we have received a lot of comments there, but time will not permit us to read them all out. In his presentation to us, he has re-emphasized everything that's been said earlier. More importantly, he told us on how to market ourselves, emphasizing the need for us to approach selling ourselves to other professionals, but not through confrontation. Emphasize the need for us to be outcome oriented, and he touched on MTN, and this particularly coming from a community pharmacy. So we'll see that there is no too much difference in the services rendered by hospital pharmacies.
I'm done, Dr. Ole.
Yes. Okay, our community pharmacists. He touched on what we call the 9-star pharmacists here, and the need for us to update our curriculum, and then the need for us to have synergy between the practitioners and the trainers of new pharmacists. That I can testify to, that we saw much more in the US when we were there. So once again, we want to thank you very much, all our panelists, for this afternoon. And we're now going on to take Dr. Kisler Amebo if his network is good. And after that, we'll take brief comments and questions. If you have questions, Abdusalam Ayodeji, I know you've signified to ask a question. If you have questions, please check on your screen. There's a place where you can raise hand. So just raise your hand and then we'll recognize you and pick the questions, the number of questions that we can pick. So we will be able to take 2 questions and 2 comments. I want to recognize 1 or 2 people. All right, Dr. William, I can see you raise up your hand. Dr. Tariam, I know that you are on the platform. You are welcome to this meeting. And pharmacist Mrs. Kuranga, I saw her too. You're welcome to the platform. So we will take 2 comments and 2 questions. First, I'll call on Ayodeji Abdusalam for his question, and then we will take Dr. William. All right? Ayodeji Abdusalam.
Good afternoon, sir. Good afternoon, sir.
Good afternoon.
All protocols duly observed. My name is Abdusalam Ayodeji. Actually, I have a lot of questions, but I'll try to streamline into about 2 questions, sir, if I'm allowed.
All right.
All right. Thank you, sir. My question goes to Dr. Pharmacist Charles, especially. And the first question is about specialization and being up to this. I would like to combine a question into that. I'll just simply ask him, I'm a young pharmacist and I just want to know at what stage exactly should pharmacists start to specialize in specific areas? And the second question is that, will he consider advanced educational qualifications as a basis for promotion in civil service when it comes to pharmacy practice? Those are the 2 questions I have for him. I'm talking about our curriculum, actually. I think, well, the curriculum is very good, fine, but at the same time, there are a lot of overlaps even within the curriculum. That is, even if we are not ready to actually, update the curriculum in the country. There are a lot of overlaps. You learn the same thing in like 4 departments during the course of your 5 years. You repeat a lot of things. And that being said, Pharmacist Ibrahim made mention that they don't take pharmaceutical chemistry and pharmacognosy in the UK. I don't really know how many medicinal plants they have in the UK. I don't have the idea. But the thing is, in Nigeria and Africa, we are blessed with these plants, and that is an area we can exploit. I believe that's an area we can still exploit, because these 2 areas actually they remain core branches and are important aspects in pharmaceutical research. All because I'm not saying concentrating on pharmaceutical is that's absolutely wonderful, but we can't afford to actually throw away pharmaceutical research. That's my own suggestion on that. And again, on PCN and pharmaceutical industries being helping in education and teaching pharmacists, coming to the hospital for work rounds, and pharmacists in practice, helping the pharmacists in academia, in training pharmacists. That's a wonderful idea. So I would just like to chip in that hospitals in Nigeria should actually encourage having a standard quality assurance. Because what we know is that, and I think this is true, what we know is that most of these industries, I don't think any other external body is actually, trying to check what they do with respect to the medications they bring from their industry. We don't know if their products have actually the required quantity of active ingredients, because we don't know if 500 milligrams, if the active acetaminophen in the paracetamol tablet is actually the quantity required.
Please, can you go to the question straight away, please? All
right. So the question is not really a question. It's just okay. Maybe I should put in the question. Do we think hospitals should have quality assurance units so that we assay the drugs that come in from various industries we collect drugs from. And if they can't add, we can they just collaborate with faculties and pharmacists that are very close to them. Thank you very much.
Thank you. Okay, so Dr. CNN.
Okay, thank you for that question. Actually, the first question you asked, you were asking at what stage should specialization come in terms of pharmacy practice. Now, I will tell you, if you are doing clinical trial, there is this what you call preclinical and clinical trial. Even I think there is one they call new clinical. There is one they do, but I've forgotten the name, but we have preclinical and clinical. If we are talking about specialization in pharmacy, I think it should start from our universities. If in our university curriculum, we make it in such a way that during the clinical pharmacy, they bring out different courses: pediatrics pharmacy, geriatric pharmacy, this one, pharmacy, quality assurance pharmacy, this one. From there, students can begin to develop interest. While I was in school, because I did my IT in year 2 or so in Unipen, I did it in a community pharmacy, and I was very close to a hospital. I developed interest in hospital practice, anything clinical. So if we should, as I suggested earlier, let the clinical pharmacy, let there be courses they call pediatrics. Let's have it, because like I'm involved actively most times in clerkship with students. But you discover that somebody is in classroom, comes for clinical lecture clerkship, he doesn't even know what is pediatrics. He will be confused. Say, what do you mean by pediatric pharmacy, oncology pharmacy? So it has to start from the school. We're supposed to have courses like that in clinical pharmacy. Again, when pharmacists are being employed in the hospital, I personally don't like this idea of employing a generalist. Employ pharmacists as resident based on a particular specialty. Look at the lab scientists. If they're employing, they will say this one is chemistry, this one is microbiology. Why are we doing jack of all trades? Let there be specialization while you are being employed. You know the area you are going, so that you become an expert and authority. That's for the area of specialization. Then the area of advanced education, you say whether advanced education will be part of promotion in civil service. Well, the answer may be yes or no. Remember that hospital runs separately a kind of from university. In the hospital, what's supposed to affect promotion is the professional qualification. I think there is difference between professional qualification and academic qualification. Masters, PhD, and whatever, from what I know, somebody may correct me, might not be other relevant in the hospital, except if we can bring in something like clinical pharmacy, which is, we can say, okay, masters and PhD in clinical pharmacy will be recognized in hospital. But ideally, what is in the hospital, what we normally supposed to be recognized, something like Pharm B, Pharm D, fellowship, any professional, maybe you went into any training, maybe quality assurance, any special training you get, that one's supposed to be added to your promotion. Do you understand what I mean? So something like academic masters, maybe you are in hospital, you have masters in pharm. I don't think it has. If you do it, remember we are in a country, if you consider masters, people in other areas, and there's confusion, because we talk about specialization. Because in the hospital, once you are working in hospital, you talk about specialization in residency, West Africa, postgraduate, B Pharm, Pharm D, any other certificate you added. I think that one should actually add. It's not this issue of first come, first serve. Once you graduated in 1960, every 3 years you'll be going on promotion. You see somebody that is promoted who doesn't want to, because somebody knows he's going to be promoted, he doesn't even want to read. But if you are stagnated because you didn't add knowledge, value to yourself, that's your cup of tea. But if you know that your promotion depends on any extra qualification and any impact you provide, I think that will make us better. So that's my answer for now.
Absolutely.
Thank you very much, Dr. CNN.
Should I?
Yes, sir. You want to make a comment on that?
If possible. I think, thanks everyone for listening. I think people have got the impression that I've said that pharmacognosy and medicinal chemistry should be banned or should not be. No, that is not what I'm saying. I think it's because of the fact that I had to rush through the whole presentation because of so many things that I had to say. What I'm basically trying to say is that I know the importance of this, but I think we are doing it in too much details at our undergraduate level. That's what basically I'm trying to say. I'm not saying there are so many things I was taught in pharmacognosy when I was at University of Ife. So many things about the names of this plant and this plant, and I have to cram everything just to pass. Right? So it's see what the difference between us and between pharmacy practice in Nigeria and here is basically about application of knowledge.
Yeah, that's true.
It's application of knowledge. There is no point in us cramming so many things that at the end of the day you will forget, that you cannot really apply. I'm not saying that, see, in universities here, pharmacognosy is still being taught. But what they do is that it's at the research level. They still use it. They still use plants. We have a company called Holland and Barrett. So many people go in there and buy herbal products. It's an area that people venture into. I'm not disapproving that, but I'm saying that we should limit the amount that we are teaching them. There is a way, somebody has said it earlier, we might need to review it. And then so that we can concentrate on things that are relevant in this world now. We can teach our students about pharmacognosy and medicinal chemistry, but we need to streamline them so that we can teach the relevancies, not things that are not really relevant. That's what I'm trying to say.
Okay, now, thank you very much.
The other thing that was mentioned about specialization and academic qualification, I'll use myself as an example so that we can really get to know how this thing works. The way it really works is that when you qualify as a pharmacist here, you need to first of all be a generalist.
Yeah.
A generalist in the sense that you first of all, because you are just graduating, you need to know the various aspects of pharmacy practice. The same thing is applicable to the doctors. They are taught everything. They are taught the different systems. They are taught everything. They are taught the different systems from the head to the toe. So they need to know everything. They need to know everything. So for us as pharmacists, I think one other thing that I'm thinking we are missing is pathology, which is pathophysiology, which is an area that I think we need to really focus on. But the good thing about the pharmacy practice here is that when you qualify, especially when you work in the hospital, that's one good thing about the hospital practice here. When you start working in the hospital, there is what we call clinical diploma. So we have various bands. I think if you see my presentation, we have various bands. We have band 6, band 7, band 8, band 9. And in between those bands, we have maybe 6A, 6B, 6D, so like that. And you have under band 7, band 7A, band 7B, so you can progress that way. So when you're on band 6 level, you can then be able to be put forward to go for your clinical diploma program. So that way, they will teach you a lot of pathophysiology. Although you are taught at your undergraduate degree, they cover so many areas. But at that point in time, it's very difficult for students to be able to understand so many things. So when they finish and they come into practice in hospital, they are then able to, because they are then directly involved with patients every single day. So what you learn by going to uni, you can then be able to practice it when you are at work, by going to the ward, by speaking to the patient, by actually practicalizing what you are learning during your clinical diploma program. Then when you finish that, if you are then able to, you get your certification, then if you are then able to pass at interview, it's not about years of practice at all. Then you can then be able to graduate into band 7 post. And at band 7, then that's how everything, and then from band 7, then you can then start probably being specialized in other areas that you want. But at that level, you really need to there are other things that you have to really be involved in. You have to be involved in research, direct patient care. You have to show evidence. There's credentials that you have to show before you can go to that level. So it's not about it's about.
Thank you very much. Yeah, thank you very much. I'm sure the message has been passed. The first question was, at what point should specialization be introduced? And I want to say thank you to Dr. CNN, but I want to go with Pharmacist Ibrahim. Just if we take a cue from the MEDI, is that you must first have the generalist approach. Even in the teaching of pharmaceutical care, you first have the generalist approach, and then subsequently, if we have a well-defined policy for pharmaceutical services, like the medical services is, you now have people progress to area of specialization. It is in the absence of that now that we see people from hospital go for masters in clinical pharmacy and PhD, because they crave for specialization, which I think is still okay in the absence of that. But then I also know that CPAN is working on that now to develop specialization for us in the clinical area. And of course, the second thing that question was asked was on the relevance of certain courses that we have in our curriculum that we still emphasize. And like Fam Ibrahim said, we were opportune to be in the United States in one of the universities there. We saw them do dispensing that we hammer here and we make it a 60% grade. And if you do not have 60%, people carry it over in ABU for years. People are there. And when I asked them, how long are they going to do this campaign? They said 4 weeks. They're going to be exposed for 4 weeks to just know that this was done before these other things come. And we will be in ABU there. Every week there's for 2 semesters, 16 weeks there, 16 weeks there for 3 years. And then we are in the hospital now. What are we doing with that? Nothing. That is what they are saying. The people who are stagnated, they do not allow them to move forward because they didn't pass that course that they will come out and never use. And that is the point that they're making here. There's nothing wrong with exposing us to it. Expose what is pharmacognosy. We saw there today, those things were not on their curriculum for beginners. But when we ask questions, they say it's at the research level, as Dr. Lawrence has also told us. That was we buy into that. But we have a very long curriculum for us there, 6 years now to make PharmD, and in the US it's 4 years for someone who has never had any knowledge in pharmacy before, and 3 years for someone who has knowledge in pharmacy. You can imagine. And then with your 6 years, if you get out there, you can practice here. It's unfortunate. So we need to really sit down and redefine and refocus what we're doing. Thank you. We will have room for one more comment and one more question. So I will take on Dr. William. Yes, you have the floor.
I really need to appreciate all the panelists and all the participants. That has been very beautiful. This is true talk to ourselves. They say the truth is very bitter, but it's always the best. With regards to PharmD issue, we want to know that the University of Ilorin has started the PharmD program. And of course, the kind of resistance we have from other departments, we are there. The current situation is we have patient-centered care. And that means that the patients are the center. Products, yes, but unless the patient takes that product, the product is useless. Exactly. That being the case, the curriculum has to be developed and implemented along that line. But others from other departments want to say, clinical. You are taking the lead, stealing the show. But it has to be there because it is patient-centered care. Other departments can also tailor the content of their lectures to become patient-oriented care. If everybody sees the patient at the center, this kind of infighting will not take place. So we need this kind of bitter truth to ourselves as pharmacists. We are not saying other departments are irrelevant. We are all relevant, but it must be tailored towards the care of the patient. That calls for a review of the curriculum. We also want to appreciate that the area of specialization is very, very key. Today, pharmacy is diversifying, and there are two areas of pharmacy that we are always ignoring. And I will continue to seize the opportunity to let our colleagues know that they are gold mines. One of them is veterinary pharmacy. The other one is public health pharmacy. Pharmacists are always reactive. We are not proactive. What are we doing to tap into this gold mine? My experience during the residency in the PharmD shows that as pharmacists, we need skill acquisition. Dr. Ole was my preceptor, and he remembers the experience with a patient that we had to carry out intervention. The consultant was so appreciative, the professor was so appreciative, and the question was that, are we being paid for this work we're doing? So if we continue to exert ourselves, have the necessary skill acquisition prerequisite, make ourselves available. We know it is a lot of work, but for us to be relevant, we must do the work first so that others will recognize us. Thank you so much.
Thank you very much. We will take one more comment or question, and then we'll wrap it up for today. I'm not seeing any hand up.
My hand was up now.
Okay, Dr. Kukigam.
Yes,
you have the floor.
Yes, thank you so much. My question is directed to Farm Lawrence Odetunde.
Yes,
can we say that drug therapy problem is synonymous with medication therapy management, which is the sole item in pharmaceutical care? Can we say medication therapy management is synonymous with drug therapy problem as a specialist?
Yes, ma'am. That is taking proactive steps to prevent, identify, manage, therapy problem, whatever it is. That's the bottom line, because it's all about patient. Even though we're in retail, we have a lot of machine that, dispense drugs and all that. Sometimes I don't have technician with me, but the system is such a way that the software that we use will automatically review all the drugs, both present and past, that we have information about. And anytime the patient comes in, update their information, whether they have been to another pharmacy, that we are not aware of medication they are taking and all that, so that we can have a holistic approach to reviewing their medication. And if there are situations, like for example, I work night shift, and people may come that are not even Walgreens patients. They come from emergency room, and because we're the only one open, or they had no choice, they need the medication at that point in time. Even though we don't have access, they will take proactive step to find out which other medication they are taking. Do they have particular ailment? Like let's say, for example, somebody is prone to arrhythmia and is having Zithromax. We know that the doctor may have to change the medication, maybe to Bactrim or something that is natural. So all those things, it just we take proactive. Even though on the long run, Walgreens is about profit, but then without taking care of the patient, there'll be no profit. The same thing in community practice in Nigeria. It may look like we are just like another, a medicine store. We shouldn't be. We have to differentiate ourselves. Yeah. We have to do something extra that will make those patients to come. It's not just only about price alone most times. But I, for example, if I come to Nigeria and I establish a community pharmacy, I want to make sure that every patient that comes to buy prescription drug, the data is entered into our computer system.
Yeah.
Not OTC, but it's important. We have to do it. Nobody's going to do it for us. Though the laws are there, they are not being implemented. But we have to take proactive, step towards that to make sure that as professionals, we differentiate ourselves from all these medicines dealers and all that. And that's the bottom line.
Exactly. Thank you. Exactly.
Very much. Thank you very much. So we have to bring this meeting to a close.
Dr. Ole, sorry to, there was a question about drug chart. I'm not sure. Somebody raised a question about drug chart.
Yeah,
I'm not sure whether you saw that question.
it was typed in, I think.
Yes.
Okay. I did not
Look
read
at the chat.
So
Please,
should I
you
just
can
quickly respond to it?
Yes.
Right. So in terms of this drug chart, I downloaded those drug charts that you see. I downloaded it on the internet. So you can just Google these things. It's all available free of charge. There's nobody that needs to finance these things. You just need to download it, print it out, and then you can start with one word. Just start with one word, implement it on one word, work with the physician on those words, and then start with a physician that you know very well, that can work with you. See the impact, and then when you have that impact on that word, then you can start cascading it to other words. Because by then, when you start doing that, by the time you do that and they can see the impact, I'm telling you, the hospital management will invest in it.
Exactly, you got it.
But if we don't start these things, it's not going to happen. There will be no change in our practice.
All right. Thank you very much. It has been a wonderful session, and I want to believe that we have been greatly enriched. We want to thank our facilitators, our panelists, starting with those from the diaspora, Pharmacist Ibrahim Rahman and Pharmacist Lawrence Oyetunji. Thank you very much for gracing this session.
Hello. Hello.
Yeah.
Hello. I'm seeing a medical doctor trying to come in. One Dr. Wako, I don't know. One Dr. Wako Azubike. I don't know whether you are seeing a medical doctor. I don't know whether he wants to ask. You can allow him to talk. He's a medical doctor. He's a proof pharmacist. I don't know whether he's raising his hand. One Dr. Azubike Wako. Are you seeing him?
Yes.
Are you seeing? He's a medical doctor. You can allow him to talk. He's part of pharmacist. Azubike.
Please.
Benjamin.
You have the floor, sir. We are happy to have you in our midst. We do not know you. All right. Dr. Wako, you can mute yourself and talk.
Azubike.
Dr. Wako Azubike.
Benjamin.
Unmute yourself. Unmute yourself. Okay.
Hello.
Yes, we can hear you.
Oh, that is great. I'm very much excited about your presentation. It's quite encouraging. I've been praying for this kind of discussions and meetings, and I've always believed that pharmacists are one of the bedrocks of health practices, especially in the hospital. And I'm happy things like this are being discussed so that there will be better and informed healthcare. Like I said, that pharmacists are very important, like what has been discussed. We want a situation where there will be things like we are saying, where there will be residency among the pharmacists, especially in the clinical pharmacy, so that everybody will take care and everybody will have an area of specialization. Like we are practicing here, that is one of the things we are promoting, that pharmacists should have their specialization, and so that when there is ward round, the doctor is having his ward round. I believe that is opportunity for pharmacists to be there. I may be writing 3 prescriptions. I may be writing a drug, like I may be writing erythromycin, and I now putting vitamin C. I feel it's a pharmacist who has specialized in clinical area that will be able to tell me. And some of us are very interested and willing to take the advice, because without teamwork, we can never progress. So I want to thank you very much for this presentation, and I want to tell you I'm so happy, and I'm looking for tomorrow where we will have great pharmacists that when we want to write a single prescription, we will write consultation and say, dear pharmacist, could you please review this patient and advise as necessary, because all this will bring a better outcome, low side effects. And also, I wrote something about pharmacoenvironmentology. we also we want your expertise to come in. You see sometimes when you see drugs are being disposed, there are some of drugs that are not biodegradable, and they are being disposed in waters and you see that they will pass through the channels of water and affect our food, and at the same time affect what we are eating. So all those things, that is where I'm trying to do some research. I'm based in Lesotho here. So these are areas we want to collaborate with the pharmacists and see the effects on different parts of effects on kidney, effects on different systems in the body. So I'm very excited. Let me just end here and say that I'm too excited.
Thank you very much. Thank you very much. It's very exciting.
He's a pediatrician. He's a pediatrician. Okay. He's a pediatrician.
All right. We are happy to meet you. So we want to thank you all. Again, Pharmacist Ibrahim from the UK, Pharmacist Lawrence Oyetiji from US, our own Dr. Charles Wako and Dr. Wako from Lesotho. Thank you very much. Dr. Williams, you are raising your hand. Please, you have to close this meeting now because we have another meeting. So it's been a wonderful time having you all our special guests. We are grateful to you, Dr. Kukigam and Dr. Amibo, and every other person, important dignitaries here. We have over 50 people in attendance, and we cannot just mention you all. Thank you so very much. It's been a wonderful time with you.